you. Those online, I can see Simon Bryant. I can see you, Michelle. Welcome to see you. And Robert Ebus and Francis Francesca. Is it Francesca White? There. So welcome. And welcome. Probably good to actually just introduce yourself. So I'm Councillor Michael Lilly. I'm chair of the committee.
Councillor John Nicholson, vice chair.
Councillor Joe Robertson, committee member.
Joanna Smith, manager of Health Watch Isle of Wight.
Leanne Arnold, manager of the Pole Street.
Reverend Mark Evans, minister of Newport Congregational Church and helps run the Palfrey Pantry.
And Nigel Hartley, chief executive of Mountbatten.
Councillor Debbie Andre, cabinet member for adult social care and public health.
Rogodian, director of adult social care and housing, and the statutory director of adult social services for the Isle of Wight.
I'm Laura Rice. I'm the safeguarding adult board manager for the Isle of Wight.
I'm Joe Smith. I'm the chief officer at the Isle of Wight NHS Trust.
Hi, Ursula Hor.
Hi everyone, I'm Scott, the associate director of primary care on the Isle of
Julia Baker Smith.
Melanie White, I'm the statutory.
Welcome the press, Louise, and welcome Mr. Knowles in the public gallery. So thank you, and welcome colleagues online. We've got there isn't any fire drills that are happening, but if you hear the fire alarm sound, please treat it as a real emergency and evacuate the building via the nearest safe escape routes. The nearest escape route is via the stairs to your left as you leave the council chamber or public gallery. Just follow the signs. Exit via the back door of the building and walk across the inner car park to the evacuation point, which is the pavement opposite the police station. The lifts can't be used in the event of an emergency. Please do not re-enter the building until you're advised it's safe to do so by a member of staff. Thank you. If you could also turn your mobiles off or put them on mute. Thank you. Welcome. Go there. Apologies, and if there are any changes of membership, I've got apologies for Councillor Drew and Councillor Joe Lever. I haven't got any others. Can I make a note to councillors in your different groups that if you can actually get replacements before the meeting, it's always very helpful, especially when we've got many others who've given up their time, so it'd be helpful. We go on to minutes. We've had the minutes, and everybody in agreement. Can I have a proposal for the minutes? Councillor Nicholson, were you here the last meeting? Second, and can we just have a show of hands for the minutes? Thank you. I will sign them. Any declarations of interests? Any on any of the items? No, thank you. We go to item 4, which is public question time. Have a one question from Mr. Knowles. Would you like to go to the? Would you like to speak your question, Richard, or do you want me to read it out? Yes.
Right. In the years since the Isle of Wight Council started to commission a local service for the supply and return of medical sharps bins, many of the delivery systems used to administer medicines, particularly those used for type 1 diabetes, have become larger. As a consequence, the 1 litre sharps bins currently within the contract are no longer appropriate for around 1,000 island patients with type 1 diabetes who use this life-changing technology. Given that this number is likely to increase, how acceptable is it that after 2 years of communications between the relevant stakeholder organisations for 5 litre sharps bins to be added to the service specification, there has apparently been no meaningful progress, and that, as a consequence, island patients are struggling to obtain the significantly larger numbers of the 1 litre bins that are now required to safely store and dispose of these larger medical sharps?
Thank you, Richard. There might be people here also that might want to contribute to this, but this is the official answer that I've received, Richard. And I will read it out, but then if you want to come back and ask a supplementary question to it. Sharp boxes of a range of sizes have been collected for the last 3 years from pharmacies on the island from the Sharps Take Back scheme. See below for total box collection number 2020 to 2023. There are a limited number of pharmacies with the appropriate storage facilities of store 5 litre boxes that they are accepted at a number of facilities. The council becomes responsible for sharps for self-treating patients when patients are not in receipt of care from a healthcare professional at home. It is very difficult to forecast the changing numbers of those requiring this sort of collection as medical advancements change rapidly. The waste team have been ensuring that the below numbers of sharp boxes from 1 to 5 litres are collected in pharmacies. However, given the change to the size and shape of auto injectors, we are now looking to develop a pre-booked sharps collection service for larger sharp boxes. Given the costs to the authority, we're exploring the funding options, which may include a nominal fee. There's a list of figures below here, which says sharps collection from pharmacies 2022. 1 Lahaz Musa Crypto 2002. 1 El Munich Sharps 10,335. 2 El Haz Municipal Meds 12. 2 L Municipal Sharps 146, 4 L Municipal Sharps 60, 5 L Municipal Sharps 83. Sharp collection for pharmacies in 2021. I think this will be available to you. I think reading all these out, I think it's slightly meaningless. With it. Do you have a supplementary question to that? I mean, you will get a full written reply.
I was interested to hear that a range of sizes are available, because in my experience, the largest size available, is the 1 litre sharps bin. None of the smaller sharps bins are suitable, fit for purpose for the delivery system and the monitoring, the applicator for the monitoring system for measuring blood glucose. I've worked out that given my wife has type 1 diabetes and she gets through sufficient equipment in a 10-day period to require 36 or 37 1-litre sharp spins every year. So if simply extrapolate that figure by the 1,000 or so patients on the island who have this equipment, you're looking at 36,000 1-litre sharp spins are required. I've not experienced any chemist that has a larger bin than 1 litre, and that was the whole thrust of my question. And in fact, that the written answer doesn't actually answer my fundamental question: is how acceptable is it that after 2 years, over 2 years, I'm told by someone at the Integrated Care Board, that this has been in discussion with Isle of Wight Council, how acceptable is it that this situation has not been resolved?
Well, personally, I would make comment from the chair that I think is unacceptable. Is there someone from the Isle of Wight Council that could answer this question?
Chairman, can I?
Hmm?
This issue has been kicking around for the last 2 years, and it's been batted from one health partner to another, public health to the Integrated Care Board, the Integrated Care Board to the Isle of Wight Council, and then back again. In fact, Dr. Legg took enthusiastically offered to take it up. I think it was about a year ago, Michelle, wasn't it? And
yes, I think I offered.
You hit a stone wall.
I offered to look into who was responsible for the commissioning of the bins. I think that was what we did.
And public health at the last health scrutiny meeting firmly stated that the issue of collection of these 5-litre sharp spins, which have been stated on numerous occasions to be a required size, lies firmly with the Isle of Wight Council. Now, the only Isle of Wight Council senior representative we have here at the moment is the cabinet member. Debbie, can you take this up and make sure it gets sorted before the next meeting, please?
I can look into it. I can't guarantee that I will be able to find a solution by the next meeting. But I think the core of the issue for me is where the actual responsibility lies. And that's something that I am willing to look at to determine once and for all where that responsibility actually lies. Thank you.
Honestly, because it gives you little confidence in the ability of the health service, health partners, if we can't get something as simple and as basic and as essential as sharp spins collected.
I think that's a particular point, and I will say, Mr. Knowles, this committee has been concerned for some time about this. I think the key is if we can actually clarify who's actually responsible. Melanie, who actually answered this question?
Sorry, Chair, I've got my hand up. Can you hear me?
Sorry.
Sorry, Chair, can you hear me?
Yes, I can, yes.
Yeah, we've looked into this, and the responsibility for the disposal of waste products via the bins lies with the council, and that was clarified over a year ago. And I don't know which department within the council is responsible for the waste disposal contract, but it lies with the council, and I think that we need to, you know, as partners around the table, obviously need to support you, but actually the contract lies with yourselves.
Okay, can we make a note? We'll make a note of actually finding out exactly, and ask them to also respond to you, right, in getting a full answer. Well, I think one of the questions that you thankfully raise is we need a lot more than the 10,335 that are actually mentioned on this list, all right, of things. So thank you very much for raising this, and I think we as a committee would like to get answers. Thank you.
Very, very briefly, A related matter, according to the progress and actions on actions and outcomes, 4th of September 23, a related matter was brought up. An update was requested on whether a permanent solution has been agreed for 51 sharp bin collections. And at the moment, we've not had a response to that since the 4th of September 2023. The only response is awaiting a response from the service director on the progress with implementing a permanent solution, which isn't really a response.
Thank you, Councillor Spink, for raising that. When we come to the update, I was going to actually highlight that. So thank you for highlighting it. Mr. Knowles, we do have this issue on our actions, and we will just add your particular question to that as well. Thank you. Yes, you can.
While we're waiting for this, what are the patients on the Isle of Wight expected to do with their sharps if they cannot, one, obtain enough of the 1 litre bins, none of the 5 litre bins? What are they to do with their sharps? In the old days, we were told, in fact, we used to tell our patients, get a fabric conditioner bottle, and once it's finished, stick your sharps in there, wrap it up in newspaper, and put it in the domestic waste. Now, unfortunately, I've got evidence that that is now happening for some island diabetic patients. Sharps are ending up in the domestic waste. Others, myself included, on behalf of my wife, are taking screwdrivers and pliers to these items to remove the needle from them so that all that is left is harmless plastic in order to make use of the small capacity of the 1 litre sharps bins. What are island patients to do while the health and social partners are working this out and continuing their 2-year discussion on the matter?
I think that's a very, very good question. And I think if that question could go to the Isle of Wight Council, who seem to be responsible for it, and we'll get you an immediate reply to that. I think it's a very, very valuable question. We can't answer it here, but we can make sure that question is put forward. Thank you. And we'll get back in the next week, hopefully, to you regarding that, because I think that's an urgent question that needs answering. So thank you. And thank you for coming to do that. That's very helpful. Okay, we go on to progress updates, pages 13 to 14. I think we've already covered the item, Councillor Spink, regarding the sharp bins, which are on there. We've obviously, on mental wealth, one of the things was having a journey map being sort of worked on, that we could actually particularly, coming from our meeting or last meeting, I'm told that there's work in progress from Dr. O'Neill about that. So if we can actually have that at our next meeting, that would be useful. We have had the report back on the 1-1 service, which was particularly requested by Councillor Lever, who's not here, but we'll make sure that has been circulated to all members. On this issue of compliance of accessible standards, which is wonderfully continually raised by Mr. Clark, and I'm sure a number of us regularly get telephone calls from Mr. Clark about the issue of the size of print. Can we, I think one of the things that he was raising was the about whose responsibility, and I think particularly from the Portsmouth side, that he was particularly raising the issue of, this is the appointments cards and information for people that are partially sighted, right? And he's insistent that there hasn't been compliance with the law in this regard. And we still haven't had a full back response to that. Obviously, Natasha's not here. If we can make a note regarding that.
Chairman, can I make a comment?
Yeah.
Yes, according to Mr. Clark, and he said he'd send me the evidence, he had a response from the Integrated Care Board, the Hampshire and Isle of Wight Integrated Care Board, saying that they didn't feel that they were responsible for enforcing this part of this requirement, legal requirement. And that was in direct contradiction to a government letter that Mr. Clark had received, saying the exact opposite. The integrated care boards are responsible for enforcing contract conditions, particularly accessibility standards. So this again is another very, very simple issue that has been kicking around for several years. I think the Isle of Wight isn't as bad as it used to be, but Portsmouth now seem to think that they're immune. And it'd be really good to have that resolved, this simple matter resolved.
But if we can, we're still owning this issue, and if we can get a response back, it would be useful. On the dementia strategy, we have got a report back on the Afton ward on the agenda, so that we will leave that to the agenda item. And dentistry, we have got dentistry on the next meeting in June, but I'm proposing that we raise this issue because it's such an important issue when we talk about the work plan, and we will raise the discussion about that then. Is there any other items about the work plan that committee members want to raise? No. If we go on to health inequalities, and particularly as a committee, we identified food poverty as a clear health inequality on the island. And one of the things was that some members, I know particularly Councillor Downer, who I think is on his way, that's probably be late, and myself and Chris Orkin from Health Watch had a visit to the Congregational Church in Newport and visited the food pantry. Thank you. It was very enlightening. I have to report back to members there was a very large amount of people queuing for the pantry and accessing it, and got I think a very good picture of the real need or the need of such facilities. Sorry. I did actually say, Councillor, about putting mobiles, so please, can you? The food bank have supplied some data, which I know perhaps some of the members will have questions on. Unfortunately, they couldn't be here fully in person, although I know Leanne has some experience of the food bank because I worked there. But really over to you, Mark and Leanne, and for you to give really about sort of 10 minutes a kind of insight and how you see the importance about how we tackle health inequality and particularly food poverty on the island.
Thank you very much.
Thank you.
When the scrutiny officer, Melanie, emailed me wanting statistics and things like that, that's not what I do. I know the food bank would be very good in giving you statistics, and Leanne has given me figures for the pantry that in 11 months since we were funded and less than obviously a year to us opening, we have just under 1,000 households represented at the Powell Street Pantry, which is about 943 adults and 463 children. As Michael said, we get very busy in a 4-hour period on a Wednesday. We work closely with other pantries on the island and different ideas. But if I can take you back a little bit, like I did to Michael and his friends when they visited 7 years ago, my wife was coordinating the street pastors and working with the local police, obviously the Isle of Wight Council, and was approached about night sleepers and different people on the streets, and could we provide somewhere, working with the church on the roundabout who were hosting the food bank then. Churches worked together to see what we could do and provide some basic night shelter and food, which ended up with the pop-up soup kitchen using the foundations of my chapel, and us opening our building to waste food from supermarkets, hotels, etc. So 6 years on from that, so kind of maybe flying under the radar a little bit in just giving away waste food and looking after people, which started with the homeless to sofa surfers to struggling families, pensioners. We saw a growth. So just over probably about 14, 15 months ago, I met with Councillor Debbie Andre at the church in Sandown, Christchurch, just to hear a little bit about pantries. And it just captivated me as a minister, as a man, as a husband, somebody that has seen many people, not just on the island, but in London before, struggling and a need for collaboration to work together. So the vision of the Powell Street Pantry came, and I was able to build a team around us. We were supported by the Isle of Wight Council for Connect for Communities and government funding to set up the pantry that opened, as I say, 11 months ago. And from maybe seeing 60, 70 people on our first 4 hours, that's kind of grown to about an average of 120 to 130 each week. And I don't want to bore you, but for their £5, they get basically 15, £20 worth of food, depending how they shop and choose what they want. And that's where my health concern comes, because where we were initially trying to use fair share and getting fresh fruit and vegetables and try to encourage people to do that, trying to encourage meal deals to get more food for their money, unfortunately people weren't wanting the fresh products. They were wanting something quick and simple, a microwave meal, something they can put in the oven for 20 minutes. And it kind of broke my heart, because it wasn't just that healthy eating that we were trying to promote and different courses the Isle of Wight Council and others were providing. It was just that simplicity of sometimes what people can cook for themselves or what the children were like. And even if we were trying to dress up a muck quiche, the kids weren't having it. You know, they didn't want fresh fruit in fruit salads or in a quiche, vegetables. And also what we found were some of the basic amenities that people would need to look after themselves. We've all heard the debate about heating or eating, but we were finding people were desperate for toilet rolls. People were desperate for cleaning products, toothbrushes. And again, I questioned, should that be what we're providing as a community pantry with the mindset of feeding people? But as I saw more and more demand and a need for people, we'd been in a place where we had been open to collect and receive sanitary ware for schoolgirls with different campaigns and different things being made available. Again, working with other churches, different organisations, we were often getting toothpaste, mouthwash, deodorants, etc. And again, you saw a need and a decline in people's well-being as they moved out of COVID into the cost of living crisis. And that again troubled me in how do we do things. So as a church, separate from the pantry, we were successful in another funding bid from Connect for Communities, where we received £26,000 to provide some food parcels, opportunity to cook meals like we do as a church on a Tuesday and a Thursday. And again, we'll find people will come and eat healthy meals if it's provided for them. Their kids will come and play with Lego or do a homework class, and then eat what's in front of them, whether it's a chicken casserole that parents were amazed their kids were eating some of the vegetables we blended in. So we could see an impact where people were desperate to have a warm meal through this winter. But then also the funding we had was for heat packs. So fleece blanket, hot water bottle, gloves, long johns, all the things that you would expect other people provide. But again, what we were seeing in people's requests for the food we could provide through the pantry was more and more hygiene issues. So again, we've built relationships with local supermarkets, but particularly through an island connection with Morrison's as a national brand, and we're able to purchase food items, hygiene items at cost price because of an island connection and something I'm looking to develop with the wider pantries. And when I spoke to Kay from the food bank last week, looking for the food bank to be involved, as I know they struggle with the growth and the demand, but people's generosity in giving funding. So what we've been purchasing recently are the simple washing pods that go in your washing machine, just so people can stay clean, along with the shower gels, deodorants, etc. And as I say, my concern as a father, as a pastor, as a husband, is just seeing people's decline mentally and emotionally when they struggle with that decision between eating and heating their homes, and things like their hygiene declining, people just having simple things like toothpaste, mouthwash, is something that we've seen being snapped up in the last couple of weeks. There's a need, and again, I think more than just giving you the statistics, what I'm finding, 3 or 4 times a day, I'm getting people coming into the church looking for me, because that's kind of the code word, ask for Mark. And if I'm not there, my volunteers, my staff will be able to provide people with an emergency food parcel, a heat parcel, or more importantly, a hygiene parcel, and how we're seeing that grow. 3 times a day, I've had people just pop in that are struggling for food, but when we tell them we've got things like washing powder, how their eyes light up to actually being given a box of simple, Persil powder or whatever other pod we use. And when talking to Michael and the members that came, I think there was a real shock potentially with some of the funding going to RIDE, and working with some homeless, talking to the town council there. What do you do with homeless when the climb in numbers from 12 months ago, 60 people living in emergency accommodation to 600, and we know the impact of the cost of living. We've seen the impact, sadly, of flooding on the island and people living in temporary hotel accommodation, sleeping on floors in hotels. It breaks my heart to hear these stories and to see some of the impact of people not always having somewhere to go and shower, somewhere to cook the food that we've given them. People simply using a kettle to cook a hot meal for their families because that's all the hotel can provide. So again, a bigger question about what accommodation there is, but for me as a minister, somebody caring not just for the people of Newport through the pantry and the church, but actually working collectively with other churches, with supermarkets, with our MP, etc., whoever it may be, just to try and provide a little bit of decency to some of these vulnerable people and their mental health. So some of the things we're looking to do in the future is provide more cooked meals, instead of making people feel negative that they're bad cooks, that they need a cookery lesson, and just create a sense of community. What we find with those that come to the pantry, because we have space at the Congregational Church, they can sit, have a hot drink, have some snacks, and just talk to people in a similar situation, and those that from my team that are there to encourage and to support, as well as people coming from Living Well. We've had different people from the mental health team within the NHS, different people from different charities, just providing some support and encouragement, from debt management to how they can make their budget increase, funding that's available through different housing associations. You just sense that people just need somewhere to be, somewhere they can feel a little bit human and not sit in the coldness of their home or wonder where their next meal is coming from. I've had parents leave our building in tears because they have food to feed their children when they pick them up. And I don't believe that's there, and we're waiting to hear the government's budgets on Wednesday to see if there'd be more funding for the pantries nationally. We've been very blessed and fortunate that, again, the government through the National Lottery have provided funding via the Culture Secretary's Fund in the cost of livings, as well as the funds that the government initially gave through the pension Department of Work and Pensions. So at the moment, what we're looking to develop, as I say, is develop our kitchen so we can safely provide more hot meals during the week, which isn't just a cheap cafe or somewhere people can come and have food donated. It's hopefully somewhere we can create a sense of community with the groups we have on a Tuesday and Thursday. We try to encourage the families to come and help set the table, maybe be involved in a little bit of food prep, certainly clearing the plates and tidying the tables. And that sense of creating family and community, I think, is what people are enjoying and benefiting. And then we hear the stories of the struggles that kind of break our hearts, that then, again, the funding we've given, whether that's simple washing powder, or I have two ladies that are going to lose their homes because of bereavement of partners, just trying to find people somewhere to live and help with their mental well-being, or just create a sense of community. A lot of people we see that are struggling with weight issues, we're looking to provide various keep fit classes. We have the space, the capacity for simple things from pensioners through all the different ages. So again, just looking at a holistic approach that isn't just feeding people cheap food, but trying to provide a quality food, a quality service that impacts mental health. Thank you.
Sorry, the range, thank you for the range of the fantastic things that you're doing. I think there's some really interesting points that, I mean, you mentioned at the end about obesity, which is a big public health issue or target, but actually, if people can't have access healthy food, right, or they're limited in what they can actually do, and they're limited in cooking facilities and so on, that's actually extremely hard to do.
Yes.
So I think the particular point is, I get that you're making is you've got to look in a holistic way in a big picture of this issue and how we tackle it. I've definitely observed, and perhaps an input from Isle of Wight Health Watch, that there are now places all over the island that are perhaps doing community meals and food. I know they're also doing quite a few old cookery classes as well, so that people can have the skills really to be able to use things in a much more imaginative and perhaps cost-effective way. And I think that definitely, I think in Ventnor, where they have particularly regarding people who experience mental health issues, I think there's a community meal nearly four times a week within that. I know that there is somewhere in Ryde every day now that you could have, I think possibly one day a week on a Sunday or something, but I think at least 6 days a week, there is somewhere in Ryde you could have a meal, hot meal, in a number of venues. And I know that's being organised by Ryde Town Council through their community development. And I think that is side. It would actually be very good to actually have a list of all those places that you could actually go to actually a hot meal within that. So thank you. Is there any particular questions that members would like to ask? I know you've had some questions about some of the figures supplied, Peter, by the Isle of Wight Food Bank.
Yeah. I'm a newcomer really to this committee. It's my second meeting. And I'm afraid I can't make head or tail of the Appendix 1 and what interpretation I should put on that. Now, I know that the person who could answer that, or was going to answer that, can't be here today, but I think, sorry, I can't see your name from this angle. Leanne. But I think, Leanne, you very kindly entered into the breach and are going to explain it as far as you're able to.
Yeah, I'll
Thank
try.
you.
So from what I can make out, obviously the number of vouchers fulfilled, say, take the first one, which is change in work hours. They've had 62 vouchers, which has fed 97 adults, 92 children, which totals 189 people fed with those 62 vouchers. Yeah.
just to explain that the food banks work on a voucher which is supplied to them by a referral organisation, Peter. So it could be Department of Work and Pensions, the Job Centre. It could be a social worker, someone in children's services. There's a list of people that have the right, particularly to the food bank. It's different to the pantries, but to the food banks, they have to get this voucher. So in a sense, someone's vouching that they need need that, but they have to put reasons, or they collect data of why those vouchers have been given. So the first one, change in work hours, it could be that people are on universal credit and there's been a change of work hours and they haven't got sufficient money for food that week. Yeah.
That explanation. I do have a couple more questions, if I may.
Yes, absolutely.
But on our focus for scrutiny, number 5, it says to review the current food model provisions for island residents, its accessibility and effectiveness. Well, I don't know what the model is, and there's nothing in the papers when I sat down to read them that really explains that. And also to determine any areas which may assist in improving the experience of the local population. When looking at the appendices, I couldn't really write much of a report on that either. So how are we supposed to answer these questions and have meaningful scrutiny if we don't have any information? Or maybe it's just me not understanding what's available. But I mean, I've looked at, I mean, that Appendix 1 doesn't answer it. The cost of living survey report doesn't answer it. And nationally, as I understand it, was only completed by 93 people nationally. So it's not really going to help the island. And then we've got some anecdotal quotes from various people. But in terms of understanding the food model and its effectiveness and accessibility, and determining any areas which may assisting in improving the experience of the local population, I couldn't answer either of those from looking at the papers that this committee's got. So I don't understand how we're supposed to fulfill our duty.
That observation and pointing that out is part of the scrutiny function. So I think the fact that, I think that's the question, is, as a committee, we're obviously highlighting that there is a particular issue. And the fact is that there needs to be better data collection and data analysis of this, because we obviously are getting from Mark, from Reverend Evans, that, and from the work of the food bank, that there's an increasing need for these such of food projects. And therefore, I think one of the things we can definitely request is that we need better analysis or data to actually look at this increasing issue. And it definitely, from my perspective, is a health inequality. If you've I've got parts of the community that do not have access to the range of sort of food, that's going to affect their health. I've got Councillor Nicholson and then Joanna, you want to come back on that, Mark? Thank you.
Thank you, Chairman. I was just going to ask, looking at Dr. Legg, if she doesn't mind, if there is any current data that gives us an indication of how important poor diet is on the toll that is received through primary care, secondary care, and then through to adult social care. If Darren Cattell was here, he seemed to have some figures. But Michelle, do you have any data in that regard?
I don't have any data to hand quite at this moment, but I'm sure we could find some data to bring back. Darren is on his way. There have been issues with the ferries, and he did text me to say he is on his way, but he's going to be slightly late. I mean, I think we know, we know very much so that malnutrition, which can manifest itself in both a low BMI and actually a high BMI. So, you know, the measure that we look at somebody's weight and height. So a low BMI would be, you know, somebody quite thin, and a high BMI, somebody quite overweight. We know that both of those spectrums can be malnourished. And I'm sure that we can look at our older population when they are admitted to hospital, and the general geriatric assessment looks at their nourishment. So there's definitely data to be had, and we know how very much important it is. I'm sure we can, if you particularly want to know the percentage of emergency admissions to the hospital, we could look at that. I mean, poor diet will have such a broad spectrum of manifestation. We could look at, you know, I will say the word dentistry as in a manifestation, obesity, cardiac issues, general health issues, and then we could look at the tsunami of diabetes that faces our population from being overweight. Again, looking at that malnourishment doesn't always manifest itself in people that are very thin. And certainly I've seen quite a lot of obese older people whose diet is actually quite poor, but we imagine them to, we always imagine somebody who's malnourished to be quite thin. So certainly I could bring some, try and look for some data for you for next time if you want.
Thank you, Michelle, for that. I think that I think part of this item was very much stimulated by the NHS saying that nationally that there was an increase in people going into acute services through malnutrition, and I think that was one of the points that started this particular question.
Absolutely, Chair.
So that would be useful, and I think if anything,
Okay.
this item is to put on the agenda this this health inequality and the food poverty. So thank you for that. Peter, sorry.
Just to say that, as I understand it, poor diet has now overtaken smoking as the principal cause of death and illness, as I understand it. Darren would correct me if I'm wrong.
Michelle, are you able to confirm that or not?
I thought my understanding was smoking was still the highest, but we can do that as a supplementary question to actually make sure. And I would just wanted to add, Chair, if I may, that we know the demographic on the island with its high deprivation, malnutrition will definitely be certainly experienced on the island. But if we have some actions of those 2 points, I can bring back something for next time.
Thank you very much, Michelle. People said turning it off. I think we had Joanna first, then Mark, and then Peter will come to. Yeah.
Thank you. Yes, I was just going to ask the same thing as Councillor Nicholson about whether we could look at the wider implications of food poverty, and that's on health services, and the increase in food poverty that we know is happening. According to the Food Foundation tracker, 15% of UK households in January, which is about 8 million adults, 3 million children, experience food poverty in January. So that's a huge amount of people, and given the areas of deprivation on the island, I can imagine a good many are experiencing the same. And poor nutrition, as you were saying, Mark, impacts on people's mental health, their ability to hold down employment, as well as their physical health. Not being able to afford toothpaste and toothbrushes, we know is an issue, and of course that just compounds the dental issues on the island. This is a huge area, and we get people coming to us that can't afford to put their cooker on. So even if they had fresh foods, that they can't afford to cook the food, so they'll go for something, or a packet of crisps, give the children, because they can't cook, because they don't have the money for the electric. So it's a lot more complex than people imagine when we look at poor diet. It's certainly not a lifestyle choice and not something anyone would want to be experiencing, but it's increasing, and it's increasing a wider group of people. So not only does it affect families and young children, but older people. Many older people are telling us they're missing meals or buying the cheapest alternative, and not all of those can get out to a food bank or to a place where they can get a hot meal. That's the difficulty, is it's identifying those that aren't able to get out and find that support.
So,
Thank you.
Sorry, Peter, I might answer some of your question as well, but I agree with Joanne. We're hearing more stories now of people actually through the winter months turning their fridge and freezer off because it's so sparsely stocked that actually in the cold months they'd rather leave milk out than use a refrigerator to keep it cold. Just briefly, to Peter, maybe answer some of your questions. I think some of the observations from the food bank is where people struggle is being referred and how many times they can receive from the food bank. And again, things that are given by members of the public and supermarkets supporting the food banks. Where the pantry differs is obviously people refer themselves. It's free to become a member. They just pay the £5 each time they shop. And again, through our statistics that we see, we're seeing more and more households coming that you wouldn't expect. People in reasonably well paid job, but maybe one parent in the home, but even two incomes within a household, people are still struggling with all the cost of living bills, etc., and the rise in food, that they see it more prudent to spend their money at a food pantry. And again, people shouldn't use more than one pantry a week on the island. But again, we're hearing people that have visited other pantries just to make their money go further. And again, that's part of my concern to how food is accessible. And again, what we try to do at the Pyle Street Pantry is provide that almost like a hub, a wraparound service. So what I'm hoping is that exercising to build up an appetite to eat something nutritious is part of what we can provide. And people just coming somewhere where they can be, particularly during the winter months when they haven't been afford to heat their home, pensioners, single parents, just somewhere they can come and be. This is probably what I forgot to say. Sorry, Michael.
Thank you. I'd just like to say before I ask my question that I very much appreciate, Mark, the contribution that you make. And although I'm being slightly critical, it's not in any shape or form of what you're doing. It's no criticism. Probably my fault for having spent 30 years as a barrister. If I see a question that I'm asked to answer, or more importantly, I'm asking a witness to answer, I like it to be answered, and I can't answer these questions. So could we have, Chair, are we going to answer the questions today? That is to determine any areas which may assist in improving the experience of the local population, and if so, on what evidence? And focus for scrutiny, I would like, please, specific details, and I'd ask for these to be minuted, to enable me to understand the full model provisions for island residents, its accessibility and effectiveness. I don't even know how many food banks there are, to my shame, and this document doesn't tell me.
I think that's a very good question. And
could we have those two, could we note it, please, that we want the statistics for scrutiny to be able to deal with items 5 and 6 at page 15.
I've got your hand up, Laura. Are you able to come in and answer that?
Through you, Chair, I think I may be able to assist. On the 1st of August, I inherited the Isle of Wight Council's exec lead role for our anti-poverty strategy, and that includes a work stream which relates to food poverty for all island residents. As part of that project, we are just embarking on a formal consultation with all island residents to identify from them what their needs are and what's most important to them. As you rightly outlined, Councillor Spink, we've got pockets of intelligence, some narrative and a bit of data in a number of different places. But what we are missing is the true story from people who live locally as to their needs in relation to food poverty and other areas. Through the work that we're undertaking and the consultation with local people, we should be in a position to be able to map the resources that are available to local people, their level of reliance on those resources, and any gaps in terms of the offer that we as an island community make available. I want to stress this is not an Isle of Wight Council strategy. This is a whole island strategy where we're working with all of our partners to ensure that we're supporting vulnerable people in our communities to the best of our abilities. I hope through that piece of work we'll be able to give you some of the answers that are very much not part of the landscape at the moment, because nobody's done the piece of work that you're asking the questions about at the moment.
Would it be possible, therefore, for this this scrutiny meeting to answer these questions is adjourned to a future date of the work plan, and with an indication perhaps from Laura, because thank you for that answer, when it would be practical to bring it back? In other words, there isn't the data for us to answer it. So page 15 is a little premature, perhaps, because there's not the data. So when can page 15 be brought back? When would the data be available?
If you're happy for me to respond, Councillor Lilly, I'd really welcome the opportunity to bring the outcome of the consultation back to this committee, together with a copy of the draft strategy that will be developed on the back of the voice of local people. The consultation will be live for the next 8 to 12 weeks. We'll then need the opportunity to gather what I hope will be a huge response to the questions we're asking. Food poverty is one element of the total package, and I'd like to bring the total package back here for you to consider. There will be a formal report. The council will be asked to adopt that anti-poverty strategy in due course, but I think there's great benefit to this committee being involved in the informative stages rather than waiting for that report to come through. I would very much like to come back to this committee perhaps in 6 months' time with the draft of the strategy and all of the data that we gather through our public consultation.
Thank you, Laura, for that. And I think if we can actually just minute that, I think two things. One, we've brought this subject, it's been debated. It's definitely something that we want on our work plan. And if we can then have the report back in 6 months, we can reconvene the discussion. I think the key is that we have put it on the agenda. Thank you, Councillor Andre. I'm going to wrap up this subject. Yeah.
Just to add, Chair, you did mention earlier that it would be good if there was a list of warm spaces. There is, in fact, quite a well-populated list of the warm spaces throughout the island where people can actually go to get a hot meal, and that's on the Isle of Wight Council website.
If we can put a minute, Melanie, of that link, perhaps we can put that link so it's actually available. Okay, thank you. Thank you, Laura. It was really, really interesting, and I think it was a very fruitful discussion, and we've got a good outcome that we can track the progress of that, and hopefully you can come back in 6 months as well. So thank you. And thank you for all the wonderful work that you do, the food bank and the pantries and a range of other organisations do. So thank you. Formally minute that. So thank you.
It's our pleasure. We're happy to help and certainly happy to come back in 6 months' time.
Thank you. You're welcome to stay, or you can go. It's up to yourself. Thanks. We're going now on to item 7, which is Mountbatten Hospice. We read I've got a report about the difficulty that the hospice, I'm trying to use the correct language here, Nigel, was actually having. So we thought it was very important that it was brought to this committee because the hospice is extremely important to this island. It does a lot of things that perhaps the public don't know of all the different services that you actually do. So really, we wanted you to come, Nigel, explain to us what your concerns are, and also what can we as a committee do to respond, especially obviously we have other partners here. And I think people forget that this committee is probably one of the most powerful committees on the island because it can actually write to the Health Select Committee. It's actually linked to the Health Select Committee in Parliament. So we do have a voice. We are the voice of residents and people on the island. So we're at your disposal, really, Nigel, to things are over to you. Thank you.
Well, thank you very much for inviting me. I'm more than happy to come and talk about some of the challenges we're facing. I think the key thing for me is that we have some clarity around what's going on because messages get out there and sometimes they can be confusing, particularly around what Mountbatten does and how it's funded. But I'd also like to say that I'm not here to criticise. Relationships that Mountbatten have are very important to us, and we pride ourselves on having strong and healthy relationships with all our partners and stakeholders. So I think that's really important. So what I'd like to, I suppose, highlight are some of the issues we're facing in the current climate, and we're not the only one in the local system to be facing challenges. But they're important because of the way the hospice is funded. And I'd just like to give some clarity on that. So the all-party parliamentary group paper that was shared, Mountbatten was involved in that report, as a number of hospices were across the UK. And it highlights some recommendations for the government, for NHS England, and also for local ICBs as they go through the kind of transformation that they're going through. I understand as well that the ICBs are under a lot of pressure at the moment, and scrutiny is important, but I think it's equally important to understand the implications of scrutiny and to talk around maybe some of the results that might ensue that aren't maybe necessarily sought after. So the APBG report is there for information. It's a very important report because in part it highlights some of the issues that Mountbatten is particularly facing. I think one of the challenges for the government, for NHS England and for ICBs is that all hospices across the UK do different things to each other. And I think that's a very important point. So for ICBs to get to grips with what hospices are doing in their area, we need some really close scrutiny, but we also need some clever partnership working. So the paper's there for your information, but I'd like to just focus on how Mountbatten is funded. It is extraordinary. Mountbatten is very central to this community, and we're very fortunate to get the support we get. But there's a lot of confusion and misunderstanding around what Mountbatten provides and what our strategy is. So I'd like to talk a little bit about our funding streams. I'd like to explain a little bit about the formal contract that Mountbatten has with the local ICB and some of the pressures that we're under. Some of the services that are funded solely by charitable income, because I think that's important too. And then maybe to think of some of the short and long-term challenges that are coming out of these things as we go forward. So funding streams, Mountbatten has two funding streams, two very large funding streams and two major funding streams, really. The first is the funding stream that comes through our relationship with this island community and the charitable raised income. This island raises about £7 million a year towards Mountbatten services. And that comes from, as many of you will know, a series of events, Walk the White being one of them, which has been particularly growing in success, from legacies, from our major donors, trusts and grants, those kinds of things. And I'd like to say that this funding stream's very alive, very well and very healthy. This island community is extraordinary in terms of what it does for Mountbatten. I think it does it because it knows how important Mountbatten is, and I think it does it because people on this island know that they will need Mountbatten should they live the rest of their lives here. So I believe that 7 million, 7.5 million we receive from our local community is at its peak. And I don't feel it's right to keep going back to that community to ask for more money to fund gaps within our second income stream that I'll talk about in a minute. So the Isle of Wight community funding for Mountbatten is alive, well, and very healthy, and it's probably better than it's ever been. And I think that's an extraordinary thing to say at a time when we've just been listening to what we've been listening to, where people are really struggling and are really challenged for money. I think in a world like it is, people want to do good, and they want to give something to an organisation that's going to hopefully do some good for them. So alongside that, we have a second funding stream, and that comes through a formal contract that we have with the local integrated care board. And we've had that contract in previously with the NHS commissioners who are on the island, and we've had it for about 10 years in its current form. It provides around 3.5 million, so it's a third of the total cost of Mountbatten. And I think one of the confusions is that that 3.5 million pays for what Mountbatten does, and the public then pay for some nice things around the side of it. The public, the 2/3 of the public givers, pays for more of what the NHS pays for. So for every pound the NHS gives us, the community put in £2, so that 2 out of 3 people get paid for by the local community in terms of their care. And that's a really important point, that we're not just providing lovely things around the edge with our charitable income, we're providing straightforward end-of-life specialist services to more people. And that's the reason for that is we've known for the last 20 years of the growing older population. The island is an outlier. We're seeing it in front of us. I know people use 2040 as a year when this big change is going to happen. But actually being 15 years or so ahead of the rest of the UK, Mountbatten is seeing this happening in front of us today. It's now, and the pressure is now. And I'm sure we're seeing that in other healthcare services too. Mountbatten's the only hospice in Hampshire with a formal contract with the local ICB. That's because we've fought hard for it over the last years. We believe it's right to have a proper agreement, a proper kind of contract where we agree what we're providing for the NHS as much as possible. 5 other hospices in Hampshire and the Isle of Wight work alongside us, don't have a contract, and they receive a one-off grant payment once a year towards their services. Mountbatten, we're told we get more money than any other hospice. That's because we provide more services through the contract that we have. And that's another important point. The NHS contract is defined in as much as it talks about the main areas of service provision that we provide on behalf of the National Health Service. So we provide specialist palliative care beds. So specialist palliative care is just another description of hospice complex beds. We have 16 of them, although the number of beds is not defined in the contract. We also provide specialist palliative care community services, including 24/7 home visiting, specialist palliative care day services and rehabilitation services, as well as bereavement services. Although those services are not defined by numbers, they're defined by the actual services that we provide. Mountbatten has seen a 250% increase in need for its services in the last 5 years, so pre-COVID. Today, I don't know whether it will surprise you or not to know that Mountbatten has 2,200 people on our books at home. They're the people we are supporting within their own homes across the island. And delivering those services 24/7 is important because hopefully what we're doing is keeping people out of hospital and keeping them in a place where they can die at home. I was talking to the night team this morning when I went in early, who'd been on last night. They'd made 8 visits across the island during the night to people who were actively dying, that if they went there would have probably gone into hospital. And that's important to understand too. So the impact is huge. So the 3.5 million from the commission contract is really the tip of the iceberg in terms of the money we get. I think over the last years, or certainly over the 10 years I've been in post at Mountbatten, We receive 3.5 million a year from the NHS with an inadequate uplift year on year. So those of you who run organisations will understand that the cost of that 3.5 million, the services that we provide for it, goes up by 8 to 10% year on year and has continued to go up more, particularly with the cost of living crisis. We normally get between a 1.7 and 2.5 uplift on our contract with the NHS. And what we tend to do is fill the gaps in that by raising more charitable income. As I previously said, I'm not prepared to go back to this community to ask for more charitable income. I think they do extraordinary things for us. So this year, I was told categorically that there would be no uplift on our contract from the NHS on the 1st of April. I was told that last November. I came and spoke to the Ireland Care Partnership a couple of weeks ago, and some of the pressures I was talking about, there have been some changes since that meeting. So it is quite extraordinary what happens when you say things out loud. So we've now had a letter from the commissioners saying that it hasn't been agreed there won't be an uplift this year, and there may very well be one. So it's important to understand that. I guess the key thing, and going back to the All Party Parliamentary Group report, the uplift doesn't actually cover the increase in costs, and we're having to look for more charitable income to do that year on year. So therefore poses a problem. But there are a couple of other things around the contract that Mountbatten provides that it's paid for by the system. We provide a lymphedema service. Lymphedema is the condition that comes with some forms of cancer, but can be hereditary. It's the swelling of limbs. And we have a specialist team, and we have about 350 people on our books on the lymphedema service. We've been told that the cost for hosiery, so the cost for the equipment that we need to do this, has now been capped as part of that contract. And that cap was hit in November last year. So everything we're now paying for that is being paid for by charitable income. The service itself actually costs twice as much as we get from the commissioners, and that has developed by growing over the years. We also provide some education funded by the local authority. The funding of that is currently being scrutinised. That education is for care homes and domiciliary care agencies, where we've been working with care homes on the island, particularly around their end-of-life care, but also around their regulation with the CQC and how they might improve that. And I think we've had an 80%, Laura can correct me if I'm wrong, change in terms of CQC inspection ratings because of care homes coming on that education programme. But it is highly likely that that will stop. In terms of charitable income, outside of the contract, we use our money to pay for a number of services that Mountbatten has innovated on. Mountbatten is widely thought of as a leader across the UK in terms of what it's done for this population, which, as we know, is an outlier. From November until the current day, we've had 8 UK hospices visit us, and hospice services from 2 different countries across the world who are interested in the model we're creating and wanting to replicate it in their own areas. So it's being noticed what we're doing. The coordination centre that some of you will have heard of is an early referral, early intervention system. That service is currently funded entirely by charitable income. We believe it's important because what we know with the growing numbers who need our care, that the specialist services will get overwhelmed if we don't find a way of managing it with the number of people coming. And when people normally access hospices in the past, they access them in crisis because they come too late. There's been no planning, there's been no conversation with the family, people don't have a will in place, all of that stuff, which is really important. So the coordination centre has encouraged early referral for people to come to us, where we do a quick assessment. We start an advanced care plan where we begin to talk to people around their wishes and plans for the future at a time when they're still well enough to make those decisions and actually benefit from that kind of conversation. So basically what that service is doing is avoiding crisis by early referral and early intervention. What we found is working with our partners, particularly GPs across the system, is there's a growing number of older, frail people. And I think old age and frailty is probably the terminal illness of our generation. These are a group of people who are dying just because they're old and frail. They don't have a diagnosis. They may not be in the system in the same way. But a number of them need very careful and very considered care as they move towards the end of their life. And we're beginning to get to know those people early enough so that we can manage that and hopefully prevent crisis for them too. The second service we provide solely by charitable income is our 24/7 home visiting. So out of hours, we don't hand our services back to the NHS to 111. We offer a visiting service, particularly for people who are in crisis. And you can imagine people living alone of a certain age, waking up in the night with severe pain, in panic, being able to ring our team at the hospice who will visit them often within half an hour to be in the home to manage that pain. And that service is completely funded by charitable income. I guess some of the pressures we're facing are to do with a lack of information from our commissioners around what might or might not happen. I understand that things are difficult and things are challenged. I understand that things have to go under scrutiny. I've got no problem with anyone scrutinising anything we do. But as we wait for this local system to settle itself and find its way through, organisations like Mountbatten are at risk because we don't have the funding there to manage ourselves through these times in order to keep ourselves going in the same way. So we have had to start making some decisions around stopping some of the services we're delivering. And we're trying to do that with the least impact possible. Interestingly, one of those services, Mountbatten, has been providing an end-of-life equipment service funded by charitable income. There is an organisation that's commissioned to deliver equipment services on the island, but it's very common for those equipment services that are not able to deliver quickly enough at the end of someone's life. So if someone wants to die at home and they need a bed delivering, that kind of thing, there's also the other side of it. So when someone dies at home, for many families, they want the equipment out of the house as quickly as possible for obvious reasons. And our service has been able to do that. I spoke at the Island Care Partnership meeting some weeks ago saying that that service will be stopping on the 1st of April. Our friends in the local authority are now hopefully helping us to take that forward and can continue funding it. So that's a real win through saying these things out loud. Also a real win, I think, is our commissioners. And I will say this with the best possible intention, slightly backtracking by saying actually there may be an uplift after all this year. As I mentioned, it might just not be enough for us to keep everything going in the same way. I'll be very clear at the end of this that I don't want any more money from our NHS commissioners and from our ICB. I want the same money that we've always had with the same agreement, but I want to do it on a fair and level playing field. And I think the uplift that we have year on year should match the cost of living, and it should match the uplifts given to all other NHS organisations across the country. And the APPG report actually insists on that as we go forward. We will have to wait to see whether that report will have any impact, particularly at a time when I know the ICB is so stretched and so challenged. More and more people are going to need Mountbatten in the future. We know that there'll be a 40% increase in the next 5 years due to the demographic. So that is considerable. More people inevitably means more cost, and that will mean more income. But I don't think we can continue to ask this community to pay for that themselves. So that's all I'd like to say. I hope it's clear, the situation. It's no one's fault, no one's to blame. We're in this situation, but it is going to have implications. Thank you.
Thank you, Nigel. That was very informative. I definitely have a very good understanding from the position. Before I open it up to questions, I'll put one very simple question to you. What would you like this committee to do? We can obviously make representations. We've obviously got representative of the ICB here about the importance of such a service. You definitely make a very, very good point, which is about how much this island can dip its hand in its pocket we are extremely good. I mean, I was a trustee of the Isle of Wight Youth Trust until recently for a lot of years, and that raises again a lot of money. So the good people, the citizens of the Isle of Wight, do contribute a lot. But it's quite interesting. We had, a meeting about food poverty, that perhaps that pocket is starting to run a bit low. And the fact that we've got an increase, as you say, 40%, we know our demographic. We do need to make representations to make sure that we have got sufficient funding for the very important services, particularly yourself provide.
So there are 1,400 charities on the Isle of Wight, apparently, all of them incredibly worthwhile, doing incredibly worthwhile things. So it is a competitive market, and I know Mountbatten is very fortunate to get the support that we get. In terms of what this committee can do, I don't know. I mean, I think I present this to you, and I think that one of the things I would ask is that the APPG report is taken seriously across the system, and the things within it, particularly around appropriate uplifts, and particularly around length of contracts with hospices, are taken seriously. I think the other thing is just people having clarity of what's going on, because I do know, and we're all in a situation where messages get a bit skewed out there, and people get a bit kind of confused. We are very well supported by this community, and that's not an issue. The issue is how much we can ask, how much more we can ask from them at a time while the NHS and the local ICB needs to sort itself through a period in order to come out hopefully the other end stronger and more secure. We can't, Mountbatten can't just hold on to wait for the result of those things. We have to make changes now, and that's the challenge we have.
Thank you. Joe.
Thank you very much, Nigel. On the uplift, I mean, from working myself in the wider sector, I know that services obviously rely on and require some degree of certainty over, as long a period as possible. And the great challenge is when a service, even a service within an organisation, is limping sometimes from year to year, not knowing what the financial position is going to be next year. I'd have thought, for starters, knowing that you're going to have the uplift that matches whatever inflationary index you want to match it again should be an absolute given. What level is the problem? I mean, I imagine it may be right from top, departmental right through. What level are your decision makers deciding within the NHS whether you get an uplift or not?
I guess I would struggle to answer that, Joe, if I'm honest. And my kind of experience of it from the outside, and this is based on no detail at all, is that our commissioners and people who we normally relate to are being asked things by another group of people who've come in to save money, I guess, or to scrutinise what's going on. And I know they're under enormous pressure to save money. But the danger is, why are we wasting time trying to save money from, which is basically peanuts within the system, where that service is being funded 2/3 by the local community, and we value that and we want it to continue. So we're not necessarily asking for more money. We're just asking for a proper uplift on the money we get. So I don't know the answer to that.
So I think, Chair, I mean, that's the problem, isn't it? That, the commissioning environment, healthcare, NHS is so vast that, finding out where the decision maker is, finding out where to unlock that problem is really, really difficult. So if this committee can make any representations, and I don't know where to and how, as to where is the decision being made to assist the hospice in their case, but as a bigger question, where are decisions around uplifts towards locally commissioned services being made? APPG is very, very high level, and of course they're not decision making themselves; they make recommendations.
Would you like to put a proposal forward, Joe, that we could then actually right from this committee that we are also concerned that there needs to be this uplift. I think especially as this very important point is the people of this island pay for 2/3 of it. And therefore we should be saying, right, on behalf of that contribution, that it is the right thing to say to the ICB. You should at least be continuing that, and you should be uplifting to that. I think that is extremely important point within that. Would you like to put that forward as a suggestion?
Yes, I think the wider point is a sort of investigative bit of work, but that's not really what this committee is here for. But on the point you're making or asking, Chair, yeah, a simple resolution that this committee supports, and it almost seems so obvious as to not needing it to be said, but this committee supports, you know, the hospice seeking an uplift in line with inflation and the cost of delivering services. This committee supports that request. And you know, the ICB hopefully will hear that and take that on board.
Do we have a seconder to that?
Yeah, I would second it, but I wonder if I could just make an amendment. I hope Joe won't mind, but that is to say, to start it with given that the local community funds 2/3, I think, is it?
Yes.
2/3 of Mountbatten Trust income, this committee supports, and then the remainder of Joe's.
Yeah.
I think that it makes the point that the community is doing a great deal, and of what my understanding is arguably a statutory duty. So I think I'm right in saying when I read this full report of the inquiry, statutory services which are sort of a statutory duty are not being funded, as I understand it. So I think given that the Mountbatten Hospice funds 2/3 of its expenses from the island community, the least that public funding could do would be to provide the same uplift as usual in line with inflation. But I'm not changing the whole motion to that, but just putting in the contribution that the community makes, please.
I think that's within that. So you second that with that slight change? You're happy with that?
Yes, yeah. So not to give Mel even more of a job of trying to capture what we're saying, but to know that this is just a standstill position. You know, this is just to achieve standstill. It's not that the hospice is looking for more money. This is just to maintain that level.
We'll come back to the vote. Darren, thank you for coming and thank you for your bravery getting over here.
No problem at all. So it's travelling back to the island because I live here, just to reiterate the fact that I do actually live on the island. And apologies for being late, Chair. So I feel whatever I say is going to be an awful response. So I'm going to keep it really straightforward and really simple. The ICB is more than happy to look at the motion if carried through you, Chair, and we will respond in due course. What I will say, personally, Nigel, walk the white together and raise money locally for the services, and we respect and totally and utterly want them to continue within our community. And we don't want to do anything to jeopardise those services because they're absolutely so well respected on the island. We do have a situation, as does the local authority, as does every public sector body, to make best use of limited amount of money that we do have. Nigel and I have had a conversation about reviewing the service specification within the contract. Nigel's right. Mountbatten are one of the very few charities that has a contract actually in place, and I think you're right to insist on that, Nigel. We've agreed to review the specification, and we've agreed to review whether that is in line with others and with the report quoted today. So we've got a process we've agreed as we go forward. The critical issue, Joe, as you've highlighted, is the uplift. Happy to respond in short order.
Okay, so Peter.
To ask a question, it's Darren, I think. Darren? Yeah. Sorry, I can't quite read the sign. Okay. One of the points made, I think, before you arrived, was that no one quite knows who makes this decision. Are you able to tell us who makes the decision and to whom our recommendation should be addressed?
Certainly, it will be the ICB board, and if you address the motion to the chief executive.
Thank you.
No problem.
Just on that, particularly come up when we talk about dentistry, I have actually written to the chair of the ICP board and the CEO, and I've asked for a specific meeting with them. They have actually responded to me, and we're arranging a date. But I think it was very important that I, as a representative of this committee, did actually have that meeting, so we can talk about some of our concerns. And in that meeting, Nigel, Mountbatten will be on our list within that, along with one or two other things like dentistry and others, but it will be. So can I have a call for, I've got a proposer, a seconder. Can we have a show of hands to support that we write that letter? Yeah. So I keep on turning myself off. Thank you for coming. That was very enlightening, and hopefully we can come back to you. But you've got our full support in continuing your service. So thank you.
Thank you for inviting me.
Thank you. The next item, 8, and then I'll call a break after that item. I think we need to move along. Got item 8, the GP surgeries. We've got 2 places over there, so if you'd like from the GP surgeries to move into that space. No? We've got 3. Sorry, you can add. It just makes it a little bit easier for you not to talk to people's backs, right? So that's helpful. Thank you.
Scott and Dr. Dan, I think.
Yeah. Thank you. Would you like to introduce yourselves and then talk about your work taking place in primary care to monitor and improve capacity and access to services?
Thank you, Chair. I'm Scott Redpath, the Associate Director of Primary Care for the ICB on the Isle of Wight.
And hello, I'm Dan O'Neill. I'm GP at Tower House Surgery in Ryde, and I'm here as the Clinical Director for the North and East PCN, the primary care network for the practices in the north and east of the island.
We had your pleasure of your last meeting, so it's becoming a habit. So thank you.
And Chair, if you don't mind, what we've decided to do for this is I will present the work that's been happening from a commissioner point of view, but we have representation from GP surgeries in the form of practice managers. We've got primary care network representation and clinical director representation, should there be any other questions that you'd like answered.
Originally a representation from Julia Baker-Smith, who actually asked for this report to be put on the agenda, which so thank you for Julia for that. Over to you.
Thank you so much. So we know that the pandemic during 2020 and what followed after that has changed the face of general practice quite dramatically. We know we went through a period where of really rapid change, where we had to open new appointment modalities, things like virtual consultations. We know that it was difficult to get in to see your GP. We know that when you did go and see someone in a GP surgery, you started seeing new people, the physicians associates, MSK physiotherapists, etc. We also, a few years ago, spent some time reviewing the Health Watch report that was put together locally on the island in terms of GP access. Very similar themes came out of the Health Watch report at the time around GP access and patient satisfaction as what we were seeing in the National GP survey. We were able to identify some themes around access, so difficulty in reaching your GP surgery through the telephone, waiting times to be given an appointment, lower satisfaction levels with the clinician that was being seen as part of that. Nationally, in 2022, Dr. Claire Fuller launched a report, Stocktake, which gave ICB some direction in terms of improving access in primary care using the multidisciplinary team approach, ensuring that there's enough capacity to focus on urgent on-the-day demand as well as proactive care. And then in 2023, the Primary Care Access and Recovery Plan was launched nationally. So the work that we wanted to share today is a culmination of previous surveys, understanding what patients have said around access and what they want, things like understanding that one modality doesn't necessarily meet the requirements of every patient, etc., and understanding the clinicians in primary care and how they service the patient's needs. So if you, the National GP Survey is published once a year. That's a survey that is sent out nationally, randomly by NHS England to a portion of the population of each GP surgery. The last time that survey was done on the island was last year, and it is due to run again this year. At the time that survey was published, it was sent out to about 4,500 people on the island, of which 1,400 patients had responded island-wide. Our practices and our primary care networks have been focusing on a variety of initiatives to improve access over the past 18 months. Some of the themes that they've been focusing on were telephone access. So all of our practices have gone over to cloud-based telephony with the ability to be able to, in many instances, handle functions that normal telephone systems wouldn't, such as callbacks, understanding the demand, understanding the time it takes to answer a phone. Having that data has enabled them to put improvement methodologies in place to drive that, and there's even more to come in terms of that. In addition to telephony, we have commissioned a ICB-wide website audit that is currently being undertaken, and the commitment is to improve digital access through our websites as well. There's also been an extreme focus over the last few years on the island in terms of recruiting to additional roles. So it's a national scheme that has been around for the past 4 years, funded by NHS, to bring new roles into primary care to alleviate the burden on general practitioners, so that your general practitioners can see the more acute patients with higher demands through using additional clinical resource for more routine care. So that work has happened quite successfully, I would say, on the island over the past while. And more specifically, over the last year, our primary care networks have been focusing on something called the Capacity and Access Improvement Plan. One of the things that we required through the Capacity and Access Improvement Plan was a clearer understanding on patient satisfaction, understanding where those requirements are to improve, and then being able to set improvement trajectories against that. all our 12 practices on the island across all 3 primary care networks agreed to implement a standardized patient experience survey. That survey came into working around about November last year. And by the time we published this report for this committee, we had over 12,000 responses. We now have edged over 13, but I don't have 13,000, but that data we don't have available today. I think if you have a look at, and we have indicated some additional slides at the back of the pack that we've presented with a further breakdown, but I think if you have a look at the highlights coming from the most recent patient survey, you can see that we have about a 90% patient satisfaction with the ease of access of booking an appointment, and a 93% satisfaction around the general satisfaction with accessing that service. What the practices in the primary care networks are doing in addition to that is they have access to the practice level data, right down to who the patient was, what they came in for, who the clinician is that they saw, because that data is recorded on the survey as well. And they are looking at further areas of improvement. One of the things that we'll be focusing on in the next year in terms of that is the telephony. So getting cloud-based telephony was step one, being able to get onto a digital system with data capabilities. Focus that has just been published by NHS England for year 2 of the capacity and access improvement plans is actually submitting data on the telephone in terms of drop calls, average time to answer the call, how many people opted for a call back, do we know how many people who dropped off actually phoned back. So that's the next step of the focus on telephony for our island patients, is to gather that data, submit it to NHS England, and then this year's capacity and access improvement plans will be focusing on that element. Something that we've also included that we wanted to share was the level of appointments that we're actually offering on the island. If you have a look at some of the data and some of the statistics that we've presented, the amount of appointments being offered on the island has increased by 56% over the past 4 years. So we've had a look at data from 2019 to this year per month. You can see a consistent growth. General practice is no different to any other sector in healthcare in that the demand has grown exponentially over the past few years and continues to do so. I think some interesting statistics, if you just have a snapshot at January, across the island in January, we offered more than 103,000 appointments 1 month alone, of which almost 60% of them were face-to-face. Did I say 100? Yes, I did say 103,000, of which 58, I think 57% of them were face-to-face. If you equate that to the amount of people that got a face-to-face appointment in general practice in January, that's more than 70% of our population. It also shows, the data also shows the response for primary care to be able to see patients very quickly. Of a very fair portion of those patients, so 35% were seen on the day that they requested the appointment, and another 10% were seen the very next day. The 45% of the 103,000 people that were treated by general practice in January were either seen the same day or the next day. If you were to compare that to some other areas across the ICB and in the south of England, we are faring exceptionally well. Our level of appointments in January, and it's been very close to that over the past while, has been offered at the rate of about between 155 to 160 patients per 1,000 head of population. To give you an idea, across the wider ICB, that is closer to about 120 to 130 per 1,000 population. So the level of appointments that we're offering on the island and that are being taken up is really extremely high. And as commissioners, we work very closely with the practices to maintain that. So we really wanted to share this with this forum to give an understanding of issues that have previously been raised, the work we've been doing over the last 18 to 24 months, as well as give some insights into future work that will be done in terms of primary care access.
Sorry, I'm doing this evening. Thank you for that detailed report. Some very interesting stats there. With that, I'm going to open it up for questions now. Within that, I've got a question from Joanna, and then I've got a question from John.
Thank you. I've got a couple of questions. The first one is there a reason that the survey went to people that had had an appointment? Because I do think you're missing those people that were unable to get an appointment or perhaps went to hospital. So the feedback we get when someone actually gets an appointment and sees a GP or a physio or the advanced nurse practitioner, the feedback is really positive. Once they see a clinician, the person is generally really happy, but it is the problem of getting that appointment where the real issues are. And the other question is, do you target specific surgeries? Because we know that surgeries operate in different ways and have different appointment booking systems. And we know some surgeries are much better at it than others. And people share that through the feedback we get, through the stories they tell us. So are you providing support for those practices that are getting kind of worse feedback, and sharing good practice from those surgeries that are getting it right at the minute?
But I can quickly say, I'll answer very briefly that we have targeted all practices, and the almost 13 responses that we have got at the moment is representation of all practices. There are small amounts of I don't want to call them outliers, but maybe 1 or 2% error. We know which practices maybe have 1 or 2% lower, and we're working more closely with those. National survey and the way that that is set up has a better ability than what we've got at the moment to reach the people who haven't been given an appointment, because randomly to anyone, depending, not necessarily if they had an appointment in the last 3, 6, 12 months. Our focus on understanding what we call the unmet demand, as you're right. Right now we're focusing on met demand. So our next focus is going to be on understanding, reaching out. Well, I don't know if anyone wants to talk about the learnings and how you guys are working together on the data at the moment.
Yes, I'll come in. Thanks, Scott. I'm Sarah Judge. I'm the practice manager for Newport Health Centre. We found the survey incredibly helpful, being able to get not only the quantitative data that we can put in the graphs in front of you, but the ability to free text into that for people to leave genuine feedback. One of the really positive things actually is, you know, we have a very open complaints process. We have to advertise that. We all know that, and we often hear the bad side, but because we're prompting people with this text message, we're actually hearing a lot more about the good and the positive experience that they're having with our practices. Going back to the national survey that was undertaken, our practice didn't fare well with that survey. A lot of the practices didn't. We took stock of what was coming out of that, and one of those things was the ability to get through to us on the telephone. I think just to put in a really practical context some of the stuff that Scott has just said around using cloud-based telephony, how do we use that data? So from my practice, we had an abandon rate on our phones of approximately between 35 and 40% across a day.
which is huge. We've been able now to understand the data, understand where our demand is in the way that any other business would, but we weren't able to because we didn't have the technology. We've got that now and we're using it. So we're able to plan our workforce in line with our demand. That abandon rate has now gone down and has been consistently down for the past 3 months to 12%. Now, my team want to get it down to 0%, but I have to tell them that's not possible because you might have rang us by accident or you dialed us from your pocket. So there is always going to be an element of an abandon rate. But we're actually even anecdotally now hearing from our patients, they've gone to ring us, they've put their phone on the side whilst they get on with doing something else, and then we answer it, and then they're shocked. So we've used that information that we've got from that survey, and we've been able to, with the support of the ICB, put in place things like the cloud-based telephony systems. And I think across the island, we're going to be seeing improvement to that, the ability to access, and hopefully we'll be able to at some point be able to survey that unmet demand. Because I think that's incredibly important for us to be able to understand the bigger picture and understand how we, continue to grow and get better.
Chris, and then Joe. Sorry, did you have your hand up?
Yeah.
And John, and then Rodney. That's really good. Over to you, Chris, first.
Okay, thank you very much. It's good to hear that progress is being made on so many fronts. Even I've been involved in the website audit. My God, that was a brain teaser. It really was. But can I just come back? Surveys are, to me, I think Joe's really brought it out, really, there needs to be far more local in the sense of actually getting the feeling of people. I mean, my last appointment, it took 4 weeks to see the GP. So if you'd have written to me or contacted me the day before, I'd be sort of on a high because I'm going to see them. But the day after I was told when it was, I'd have been, that was rubbish. There is another thing. We at Healthwatch get regularly this. It's the general practice alert status. It covers the whole of Hampshire and the Isle of Wight obviously by location. And what is particularly interesting, really, is always the Isle of Wight's return rate from GP practice on information is right down at the bottom end. Last time it was a return rate of 25% of GP practices. Is there any way of encouraging them to actually participate? Then we get a more accurate picture of whether it is. So we may not be at the OPOL 4, which is the lowest rate you can get. We may be even higher, we might be up the ladder a bit. But it's really about encouraging GP practices to actually participate in this approach so that probably others get this information as well. I've got a better feel of what's actually happening, and then you can direct our activities towards those things. Clearly, there's a lot been done, and there's a lot more to do. And I'm looking at Darren in that respect, because I'm no doubt we'll be working with you on that as well. But really, from my point of view, is can we just encourage GPs just to do a little bit more work and try and get off the lowest possible grade? Nudge, nudge.
Yes, so just a quick response. The data being referred to is called GPAS, and it is a self-reporting mechanism to the local medical committee. So Wessex LMC allows practices to report back on a Monday on a little bit of it is quantitative, a little bit of it is qualitative. It's about how you're feeling from a sickness point of view, what does demand feel like today, but then it's also they're supposed to be able to give a indication of what the activity has been like for the first few hours on a Monday as an estimator of what the pressure would be for the rest of the week. We encourage practices to report to the LMC, but contractually they're not obliged to do so. Why it is important when they do it is that we can actually see what the demand is in primary care. So we've got a dipstick early on in the week to see what the demand's going to look like. There is additional piece of work coming in the terms of the OPAL framework. So we have, as an ICB, have invested in a tool called the Apex tool. In fact, it's the Apex tool that I was able to put some of the appointment data from today. One of the next phases of work on the Apex, because it's a it's called the demand and capacity tool. Now that we've got all of the 12 island practices data flowing into this, we'll be able to actually pull that without the need for practices to submit it. And we will then work with the LMC as well as NHS Regional in England to develop a better Opal framework.
John?
Thank you, Chairman. It's probably a question for Simon, actually. Is there a correlation with demand on primary care and public health inequalities on the island? And referring to the Joint Strategic Needs Assessment, underlying socio-economic inequalities. But also, Simon, is it possible to say what the prime driver of ill health is on the island?
Very good question, John. Sorry, I'm in a bit of a noisy place. But yes, on the first one, we know there's the inverse care law where we know that primary care and all services doesn't match the need, and that's across the country, and that's a well-known fact. So we are aware of that factor. But I think with primary care across the island, we have an even spread. Yet what we'll know is that those primary care practices in more deprived areas will have higher demand because there's higher need in that that area. So I think when you look at the kind of burden of disease, and that kind of links right back to the beginning, we know that the biggest burden disease is cardiovascular, so heart health, musculoskeletal conditions, and cancers. And we know that those risk factors around tobacco, high blood sugars, and high body mass index. So when you kind of put those together, when you've got a population that's unwell and needing further interventions, and also that puts pressure on GP practices because they need to treat those conditions, and yet these people have got poorer risk factors. So there's a number of things in there. It's not a simple factor that let's put a GP practice and that will solve the problems, because we know there's many other lifestyle and social factors and wider determinants that will impact on ill health.
Thank you, Simon. I think one particular point that came out from your okay, thank you, Chris. Thank you for your contribution. I think a particular point about saying that in January, nearly 70% of the population was that, am I correct? The equivalent of 70% of the population was seeking help from their doctor. I mean, that's quite significant headline, isn't it, really? It shows that actually, and also from Simon's point, that we weren't terribly well in January. After that. Michelle, do you want to come back on that comment?
Yes, certainly. Thank you, Chair. And I would just like to say thank you, Chair, for raising the point that primary care was able to see 70% of the population on the Isle of Wight in the month of January. What an extraordinary feat for all of those practitioners out there. And that is the wider team. That's not just GPs, that's our nurses and our advanced nurse practitioners. And I'm sure the committee would like to raise that point and make sure it's noted in the minutes, because it is an amazing achievement. January is always a very busy month. We see a lot of COVID, a lot of flu, a lot of respiratory illness in children. And if you think about how hard all of the workforce have to do in order to be able to achieve that capacity to try and meet the demand, it was a huge achievement. So I just wanted to say thank you for highlighting that, Chair.
I think we'd also probably need to break that down a bit, Michelle and Simon, in future, to how we can next January reduce that number of people coming to the to the GPs within that.
Absolutely. Which is why
Can I come
that's
back on
such
that?
a good point, Chair, just to say how important prevention and looking to try to change people's habits earlier on so we can try to reduce some of the acute demand, which is something I know that Simon's very passionate about.
Thank you.
Yes, Chairman, I just wanted to make the point that surely the point is that we can't keep increasing capacity in our health services with the limited resources that we have, physical resources and economic resources, to feed an ever increasing demand that is led through socio-economic factors. Surely the sensible thing to do is to address those socio-economic factors, and we've heard those factors tonight. We're all sat around here, not seeing the elephant in the room, as far as I can see.
Well, hopefully, John, we did bring the elephant in the room tonight with our food poverty side. Lee, you had a question.
Thank you, Chairman. This might stray a bit from what we've been talking about, but I think it's fundamental. Getting past receptionists. How qualified are they? Because you nearly got to have a triage when you ring up. Thank you.
To answer the receptionist question.
Start with an apology to my receptionist before I answer this. First thing to start with in terms of our patient advisors or receptionists, all the practices call them something different, is what a fantastic job they actually do. They're often the lowest paid members of staff within our surgeries, but they are the ones expected to often know the most and take the majority of the flack. So I will always stand on the side of that doctor's receptionist. How we triage and how we offer our appointments, I think where we've seen that huge increase in demand, there becomes a greater need for us to go, you need to be seen by a doctor, or you need to just be prescribed antibiotics, or you actually need to go to a pharmacy, or any of the above. As that demand's increased, that pressure has almost fell onto our reception teams. And there's models up and down the country now, a system called total triage, where we're seeing more of that triage work being done by clinicians. So at Newport, for example, we're piloting a piece of software called ChatDoc, where instead of people being contacting our receptionist and our receptionist going, we've got these appointments, you can have one, or we've not got any because you've rang at lunchtime, so you're going to have to wait till tomorrow. We've got doctors and nurses, advanced nurse practitioners, seeing those requests coming in, and they make the clinical judgment as to whether, do you need to be seen today? Can you wait until tomorrow? Or is this a routine appointment that actually could wait until next week? So I take your point. It is often difficult to get past our receptionists. They're not clinically trained members of staff. They do get support in terms of how to signpost, but it is limited as to what they can do. So it often ends up being a case of, there's an appointment there so you can have it, or there isn't an appointment so you can't. And that's why we're seeing this shift over to a clinical triage model, so that pressure, and it is pressure. You know, I see just as I left the practice today, we had a very, very distressed patient on the phone wanting an appointment. We didn't have an appointment to give, but our receptionist was the person having to take that and having to deal with that. And they carry that pressure, and they carry it throughout their day if they're not able to give our patients the appointment they're asking for. So I'm hoping with the new model, we'll start to see some of that pressure shift off those receptionists, and for them to be able to offer a more supportive service, as opposed to it often feeling like they're the people acting almost as a gatekeeper.
Thank you. That certainly was not a criticism of receptionists with my question, but it's good to know that when this triage system comes in, that'll take the pressure off of them, and they won't get any flack. I think perhaps they ought to be paid a bit more for taking the flack. Thank you.
Yeah.
Joe.
Yeah, thank you, Chair. Thank you very much for that report. It was a comment really on some of the statistics, and is trying to understand their context. So 56% more appointments than 5 years ago. You know, one can understand that means an increase in demand by about an extra half. But a statistic like 156 appointments offered per 1,000 population weekly on the Isle of Wight compared to 120 appointments per 1,000 in the rest of the Hampshire and Isle of Wight ICB. I mean, one might expect it to be higher because our population is older. So it's hard to really draw anything from that statistic for us sitting here looking at that report and to contextualize whether maybe 156 isn't enough because it's an older population. There isn't really a reference point to anchor that statistic. A comment really on the statistics generally that you know, we can only judge them against sort of what's in front of us, and without a sort of control mechanism or any relevant explanation around it, sometimes it's hard for us to sort of understand whether it really is a successful statistic or not.
I think you're absolutely right. I think what it does show is that the demand on the practices and the clinicians and the staff within the practice is proportionally higher, and therefore the workload. And I think you're absolutely right. I think that because of the population we have, that need is higher. We still have the same resource structure and so forth. So we're having to find innovative ways to work together to try and compensate for that higher demand that's based upon the practices within the island. I think one of the things which we're trying to do is looking at how we can work more innovatively, collaboratively, working across practices. And I think some of the points raised before about how we're trying to improve things, we're trying to work together as practices within our networks of practices, between different networks across the island, pick up on the learning from pilots and so forth that have been there before. I think that's one of the key messages of how we're trying to improve is by working sort of together. And we're seeing that with, for example, we spoke on the last one about the mental health projects, where we worked with a collaborative way of working together in order to try and compensate for the higher demands that we're having to deal with. So whether or not that's sort of proportionally should be more than 150 or 120, we are having to provide that much extra workload, which is we're trying to reflect in the conversation here to sort of demonstrate how difficult it is.
Yeah, thank you. So yeah, I can see on a demand point, obviously the demand is higher. I suppose my question would be, does 156 mean we're meeting demand in a way that's being met in the rest of Hampshire at 120 appointments? You know, I have no idea from that statistic, but maybe that's not the point that's being made by that statistic. Yeah.
Just to really emphasize a couple of points, Joe, I think you're right. Statistics often get the quote, isn't there, which I won't use today, but statistics often get misinterpreted, don't they, for all sorts of I think the point today is that there was a significant issue. Some work has been done. That issue seems to be more under control, lots more still to do. Underneath it all, John's question earlier on is the fundamental one, though, which goes to some extent to address your point, which is 156 the right number? 156,000 the right number? The answer is we don't quite know. We know our primary care service is absolutely stretched all day, every day to deliver the capacity to meet the current demand. But I think if most of us took a step back and said 70% of our population are accessing primary care consistently every month, that seems high. Just on the face of it, that seems high, without any kind of knowledge or any kind of detail or any kind of, so what do we do differently as we go forward? How do we prevent rather than treat? That's the kind of conversation I think we'll start to get into that John's alluded to really. And Simon, that'll be absolute music to your ears, won't it?
I think that if we take anything of that, I'm going to have to time-wise wrap this up, is this issue of 70%. I think it needs to be really acknowledged, and perhaps we need to refer to the Wellbeing Board, right? Health and Wellbeing Board, to actually look at the preventative policies, strategies of how we could reduce that 70%, because that's incredibly high. And I think that we need to perhaps put a message from this committee to the Health and Wellbeing Board, which is looking at very much the preventative side of health in the island, is how can we reduce that level? You've got your hand up, Simon. Do you want to
I'm just
respond to
looking-
that?
Well, I'm just looking at the figures in the pack. I think we need to be careful. It's about appointments rather than people. And so, yes, it's a huge number of appointments given, and that I'm not taking away from that. But let's remember that there'll be a number of people who've had to see their GP a number of times. And Michelle's nodding. It's certainly not taken away from the amazing number of people being seen. And we're doing an awful lot of work on keeping people well and healthy. And that's in our programme, working in the Health and Care Partnership. So very happy to look at that.
One last question, Peter, because I'm going to.
Just on the survey, the survey didn't seem to me to reflect the issues that we've raised tonight. So my concern I share with Joe is whether or not demand is being met, and the survey doesn't really tell us that. The other issue is there any analysis, given that the island has a very high population of elderly residents over the age of 60, and that figure, somewhat worryingly, is predicted to increase quite significantly. So is there any way of planning so that we can deal with that? And finally, the number of appointments made, how does that compare, for example, to other areas that have a similar demographic component to the Isle of Wight? So these are all important things. And with great respect, the fact that 90 of those access felt it was easy to do, and those sort of things, doesn't really tell us the nitty-gritty to solve the problems that most people find are confronting the NHS on the island. So somehow, if I may suggest to you, the survey needs to be beefed up to answer these questions. Thank you.
I think that's the point more than a question of that.
Don't you agree?
Chair, can I come back in? Because I think, Peter, you've raised some really fundamental points there. I think we need to be clear about the purpose of the survey. And if we extend that in response to your question, your point, not a problem. We'll take that away and have a look. But I think there are more fundamental points about healthcare and, well, actually social care as well, let's be honest, and how we might address those as we go forward. That's probably slightly out of the remit of this committee, but let's have a conversation about how we might address that on a wider point.
Yeah, I would certainly welcome that. Thank you.
Thank you.
Did you want to come in on that? I'm going to I need to wrap it up.
Oh, thank you, Michael. I think just to say that there were a number of questions that we've highlighted within the report. One of them was ease of access. So that was how easy was it to get an appointment? And of those, 90% said that they found it easy to get an appointment. I think, like we've said, we want to be able to focus on that unmet demand. We want to be able to focus on that 10% of people that maybe struggled to get an appointment, and we want to be able to focus on those people that maybe haven't been able to get through. But I think, like we've already heard from Sarah, there's been great strides made in improving things like the drop rates, and that's representative of what's happening across practices across the island, not just in Newport. I think this has been a fantastic piece of work between all of the practices on the island. It shows collaboration between practices who are essentially all private individual businesses. And I think the fact that everyone's working together so well and so collaboratively is a really, really positive thing. And I think, again, that 10% more appointments being delivered on the island with the same amount of funding and the same amount of resource as Hampshire have really goes to show the amount of work that goes in. And I just want to pass my thanks on to all of our colleagues who have put in an incredible amount of work to bring these improvements about over the last 18 months.
Thank you. I mean, thank you for that. I think that's very much agreed, and thank you for coming and putting that. It's been very useful. GP surgery has been a priority of this committee for some time, so it's been really welcome. So thank you very much for coming. Thank you. Do people, I mean, are people happy to push on, or do people want a quick break or of that? Can I, before you go then, Darren, do we have representatives from the ICB here? From the ICB, I'm just, the reason. Oh, right, it was just a particular position that we, on the work plan, we wanted to brought up about dentistry. Is Simon coming into? No, it doesn't seem to be there. Huh. I know, but we still want to bring up one or two questions now about dentistry. Well, not answers, but we would like to actually, I think, get a message over. If people agree, could I bring the dentistry item over, forward with that? We know it's actually on the agenda next time in a full report, but we do want to raise certain issues in the meantime. We are, I mean, on one level, welcome the bus, but we do have concerns that all the appointments have already gone on the actual bus, which has meant that we're concerned that particularly people try and get appointments on the day, they are not signed. We are concerned, and I wrote to the chair and the CEO regarding that because I did not get answers from the commissioner, Mr. Cooper, in regard questions about UDAs and side. I did have a visit as chair to a particular dentistry practice, Denbar House, which is actually the UK's best dentist, won a national award, and I had meetings with those dentists. And one of the questions was that they desperately needed. We talk about an uplift tonight on the thing on their UDAs, which are now paid out the lowest. Most of the dentists were doing seeing 30 patients a day, right? Each one of the dentists. They have the largest practice of NHS, and they said the commissioners have never come to talk to us. I raised this, and I did get a reply, and I was told, yes, we're talking to them. When I questioned the Denbar House, they said very clearly, and they also said to Joanna at Health Watch, they haven't talked to us. If we're not talking to our dentists, right, who are NHS dentists who are on the front line, who desperately need a increase in UDAs and need to talk to the commissioners, they're the people that the solution of that. And I think that the feeling of this committee and my colleagues might think is we want to put a message very strongly to the ICB that before you come in June, we want you to talk to the NHS dentists on the island because they're delivering and actually talk about the solutions with them. One of the things that they said to me is we have difficulty doing that, Michael, because we're frightened that we're going to upset the commissioners, right? And we could, be penalised for that. Well, I said I will bring this to this committee. That is not satisfactory. The commissioners should be going and talking face to face to the NHS dentists on this island who are doing a fantastic job. We're losing some practices within that. And we do need to actually resolve this. It's brilliant we've got this bus coming over, but obviously the capacity of it, the fact all the appointments actually gives a message. but we do need, when they come back in June, to actually have a report of solution that we have got. I think it was something like, is it a third of the UDAs, right? Nearly £3 million worth, right, of not being claimed or used on the island. So this island is losing 3 million of units which actually should be dealt with. And what I got from Denbar House is they had 2 rooms, they could have 2 more dentists, and they could actually see nearly another 700 people. I think that it's very alarming that we've actually had this, and I know that Health Watch has had a similar conversation in regard this. So I think the message we wanted to come from this committee was, one, please can you talk to the dentist? Can you look at solutions? Can we make sure that this island's not losing the 3 million? Sorry? Within that. Joanna, do you want to add to that?
Yeah, I mean, I'm going to sound like a broken record, but the fact that every appointment on the dental bus is booked up now speaks volumes. We've had people today trying to get an appointment on the bus and they're told there's nothing left. That's it. As Michael said, around half the UDAs, the units of dental activity that were commissioned on the island last year, weren't delivered, which means we're getting half the provision that we should be. The dental bus is absolutely fantastic, but it's not even scratching the surface. It's a deteriorating position, and I say this every meeting. We've lost 5 NHS dental practices in the last year alone. They've either gone private or they've shut up shop because their practice is no longer viable. I had a story today where someone, a mother, tried to get an emergency dental appointment for her child. She managed to get one at the emergency dental clinic, sat there for 3 hours, and she had to take both her children with her. After 3 hours, they were both very fidgety, hungry, thirsty, and she had to go back home. And she was told the waiting list for an urgent emergency dental appointment is 6 hours. That's if you're lucky enough to get an appointment in the first place, you know. And it, as I say, it's a deteriorating position, and it will deteriorate further unless something drastic happens. We really need to reinvest that £3 million that wasn't spent on the units of dental activity last year into services right now, and we need to sort it out before the new contract starts in April, because once dental practices are tied into their next contracts, it won't be changed. So it'll be another year before we can do anything. So action needs to be done now within the next 3 weeks so that we can support the dental practices that want to help with this.
Sorry, they can't do that on the NHS. They can't actually penalise the individual within that. And perhaps they, you know, they shouldn't. There might be genuine reasons don't. But I mean, Denbar House has had 77 of those last month, which actually means they don't get paid for that unit, which actually then affects their whole viability. So we do need within that. I know in counselling, for instance, the ICB often pays for DNAs, but that is a particular issue. And these are the things that the dentists want to talk to the commissioners about within that. So over to you, Darren. Sorry to.
That's okay. I've happily respond. So the first thing is the committee will know and remember that I've been long since a champion for island dentistry. That hasn't changed in my new role, Joe, you'll be pleased to hear. And I don't think it's acceptable, current level of service that is available to the island. So that's the statement. The questions that you've posed, Chair, will take back and ensure that happens, even if I have to do it myself. That will be talking to the providers. The issue isn't about financial saving. This is about economics, providing a service to remote island population as well as access. And that economic thing is one that you've alluded to, really, which is actually private service versus an NHS service offers a different opportunity for a particular provider of a service. So that is something that we need to address on the island. It won't happen quickly, but we do need to address it. The market dynamics here on the island are different to other parts of the country. So we do need to address that over long term. Laura, you've often talked about that in terms of the care market. So there are some things, some fundamental things that we need to get to grips with, which again are probably straying far outside the remit of this committee, but they're real issues.
Is, lastly, does anybody want to add to that, what I've said? Yes.
I'd just like to say, you can have all the strategies you want till the cows comes home, but it's just getting on with it and treating people for their health and their dental health.
There you are. Thank you. Thank you for that. Thank you. Can we thank you for that, and that's thank you for enabling us to bring that forward. Safeguarding adults board annual report. Thank you.
Chairman, I wasn't clear if you were having a short comfort break. I know that there are some colleagues who would like one, myself included.
I did ask for people to do it. Should we have just a 5 minutes?
I very much appreciate it.
Can I call back people back in?
There's not many of us left now.
Not many of us left. We still quorum. Sorry, are we?
Yeah.
1, 2, 3, 4. Yeah.
Did Joe go?
Yeah. If I can get everybody out,
Rodders?
and we'll try and move quite quickly forward. And I apologise for the ones who had to wait very patiently. Leslie up there, thank you for your patience. Right. Okay, if we can go on to item 9, safeguarding adults board and the report. Every member's had this. I'm sure we've all read it. I've read it. Laura, are you going to be the one?
I am. Firstly, I'd like to introduce you to Laura Rice, who sits beside me, who is the new board manager for the Safeguarding Adults Board. Laura took over only a couple of months ago, and her taking over the board aligned with Teresa Bell, the former independent chair, leaving that post and a new independent chair coming into post. So it appears that I'm the longest standing part of the Safeguarding Adults Board now, which is very ironic. And it's on that basis that I'm here to answer any questions you have in relation to the annual report. The annual report is coming late this year due to some of the staffing challenges we had. The post that Laura has taken up was vacant for a period of time, and that caused some challenges in terms of pulling together what I hope you view as a comprehensive report of safeguarding activity for adults on the Isle of Wight over the last 12 months. I believe it's only a couple of meetings away before you receive your next annual report, which is for the following year, 23-24. So this reflects the activity of the board during 2022 and 2023, provides you with an overview of the board itself, the activity it's been undertaking, and some of the key items of note from that activity. I will assume that everyone has had the opportunity to review it. I'm very happy to accept any questions that you have of me in relation to the report, but I propose to go into no further detail, noting the time.
You and you make the point that in a couple of meetings' time, the next report is coming anyway. Welcome, Laura, and welcome to your new post. And thank you for coming, and thank you for your patience tonight. We cover a lot of ground in this committee. Have specific questions on the report? Any specific questions? I think the main thing is you say your thematic review that the particular areas of homelessness, mental health, alcohol, substance, and the suicide overdose. Is there things, have those got worse? Have they got better? And what are the lessons learned from those things? I would say most of those are probably increased, not decreased, but can you tell us?
So in terms of the Safeguarding Adults review activity, it's personal to an individual and a specific set of circumstances, where the board are presented with a number of situations where there are similarities. It is open to the subgroup to undertake a thematic review looking across that group of specific individuals and the circumstances they found themselves in. So the thematic reviews that were undertaken reviewed specific cases, and detail in relation to those is provided in the report for you, rather than being what I suspect you may have interpreted as a more holistic approach to safeguarding in general across those areas. For each of the thematic reviews, a number of actions were identified, improvements, if you like, that were needed to be made, recommendations for statutory partners to take away. And in each of those cases, as you'd expect, with the time that's lapsed since this report was originally due, those activities have been undertaken and all recommendations have been implemented. It isn't the case that there would be a fresh thematic review on the same themes unless driven by specific cases which came to the board under the safeguarding remit. So I'm unable to answer the second part of your question in terms of is it better or worse. Anecdotally, I think we'd all have a view living as part of the island's community in relation to all of those areas. But from an evidence basis and the activity of the Safeguarding Adults Board, I would be unable to provide you with any useful comment.
Any other questions from you, Joanna? No.
Are rather tedious in the sense that I've done it before, but what, as the new person here, what does, on page 97, what does this SIPFA comparators, what does that actually tell me? I couldn't work out what it's telling me, I'm afraid.
No problem at all. In terms of the SIPFA comparator, SIPFA are our benchmark neighbours in relation to our performance as a local authority. There are a number of different local authorities that are outlined on page 97, which SIPFA suggest are our most alike in terms of the way in which we as a local authority area are constructed with our demography and with our local population. The analysis that's provided on the pages that follow on sets out for you the current position and performance in relation to our services here on the Isle of Wight and how we are performing in relation to our safeguarding duties. We perform favourably in all areas, save for one, and that is the number of referrals that are made for safeguarding on the island. We see a really high number of what we term as inappropriate referrals. They are not safeguarding within the truest sense of the word. They're concerns for people's welfare or well-being, different challenges that they may experience in their home, but not safeguarding. So we see a smaller number of the referrals that come in converting to that statutory framework. For us as a local authority, our core areas that are outlined in the data continue to be in relation to neglect and omission and in relation to abuse. That can be financial abuse, physical abuse, emotional abuse, mental abuse of any type. It's categorised as one key area. Similarly, neglect and omission can be neglect of self rather than neglect of an other. So there are a number of areas where we know locally we tend to invest more time and more energy to support local people. Our conversion rate for inquiries, referrals to inquiries continues to be around 50%, which is good compared to how our neighbours are performing, our SIPFA neighbours and our local South Coast neighbours. And that's in no small part due to a really dedicated team of staff who truly put people right at the centre of what they undertake. For me, the key part of our safeguarding activity possibly isn't clear enough in the data that you see, and that's our duty to ensure that we make safeguarding personal. There's lots of buzz phrases in adult social care, things like no decision about me without me, or person-centred care, or being person-focused or person-led. All of those buzzwords in effect mean one thing, and that is that the person is absolutely the most important person within the room when these conversations are taking place. One area where our team do absolutely outstanding work is ensuring that when they consider a safeguarding situation, they engage with the person about whom that safeguarding situation has arisen. They make sure that that person is engaged in all of that activity, that they're core to the decisions that are being made, and that they get to shape the course of the inquiries that are made. What that means is that that person is truly invested in the support that's being offered to them and able to work with the team to resolve the challenges that they faced and start to rebuild their life if that's the next step for them. No amount of hard data will give you that story, but for me, that's the biggest success that comes from our safeguarding activity locally.
Thank you very much for that very good explanation of perhaps what to most people is a simple chart, but also the implications of that. Thank you.
Yes, thank you, Laura. I think that the one thing noted on some of your graphs, in particular one on page 106, the fact is compared to England, right, we have a better rate of reducing risk. And in fact, the risk remained 9% in England. We're actually 4%. So that's actually something to praise, right? Within that. Are we able to note the report? Yeah, report noted, and thank you very much for coming in, and good luck for the future. We hope to see you again. There you go. If we can move on quickly to item 10. Thank you, Leslie, for being patient on the update of the project fusion within that. Can I open to you, Leslie? Are you online?
Yes. Can you hear me okay?
Do you want to speak to this or
Are you able, can you hear me okay?
Yeah. Yes, we can.
Okay, good. So the intention had been to share with you a video, but given the time, I'm not sure whether you want to start with that. We've got a video that we can, I think has been circulated, that shares the progress with the building in the High Street.
I think we've got enough time for 3 minutes, right? The meeting really needs to finish at 8. So the 3 minutes is okay. You're okay to do that. Can we press the button for the film?
So this describes progress with the new building that you'll have seen going up in the High Street in what was HMV. That's all. Be quiet while you watch.
I'm Leslie Stevens, I'm the Director for Community Mental Health and Disability Services in the Isle of Wight Trust, and I'm here in our new Newport Health and Wellbeing Centre. We are really excited about the opportunity that this new building brings us. It will pull together physical and mental health services in the community and give us a really accessible place where people can drop in and have a coffee, come and keep appointments with the staff, and we also want to make sure that it's accessible to our community partners, that we can have community groups and activities here so that it becomes a really vital part of our community resource for Newport.
Really excited around the range of facilities we have here. So we will have a cafe at the front of the building so that it connects the building with the High Street. We have consultation rooms where people come for clinical treatments. For our staff, upstairs we have some staff accommodation, traditional desks where people can come in, write up notes, etc. We have some smaller breakout rooms for people to have one-to-one conversations, and we're going to pilot trying the use of a acoustic booth where people can make private telephone calls or perhaps one-to-one video consultations.
We've been working hard on improving mental health and community services on the Isle of Wight for several years now, and all the way through we've worked really hard with the people who use our services, with their families, with carers and our partners across the community. They've had real input into thinking about how this will work, what it will look like, what the different elements of the building will be, and I know they're really excited about being able to start to use this building in the future.
A newer building, brighter environment, more people being able to work together collaboratively to support each other, especially when working with patients that they may need additional support for, and access to other specialisms, which I think could be really good. Rather than sending emails, those services will be in the building and we can liaise and be cohesive as a team.
We are joining a new organisation called Hampshire and Isle of Wight Healthcare Foundation Trust, which will be a specialist community and mental health trust across the whole of Hampshire and the Isle of Wight. And at the same time, this amazing new building will open in the centre of Newport for people using our services. It's fantastic to see this level of investment in Isle of Wight mental health and community services. We've not seen anything quite like this before. It's a really impressive development, and it comes on the back of broader developments. So, for example, the barracks in Sandown Ryde Health and Wellbeing Centre, where we're seeing real improvements in the environments for people using our services and for our staff.
Thank you. Sorry.
Thank you. So it's not bad enough seeing yourself on a Teams meeting, to see a video of yourself is even worse. But anyway, thank you for bearing with us for that.
So when's the centre, what's the actual date for the opening?
We're planning to open it in April.
Okay, so
And you'll see, I mean, as you walk past down the high street, you can see the progress is kind of almost day by day now. So, yeah, it's exciting.
would it be possible perhaps for the committee members to actually come and visit it? Because it would be quite good before our next meeting in June.
That would be great. Yes, you'd be very welcome. You've absolutely. I'll make sure we sort that out.
Right, is there
So there were two other things I wanted to share with the committee. The first is a brief update on fusion, and you have a paper before you about that. And the second is the outcome of the Afton ward pilot. So I won't dwell on the fusion paper because you have it in front of you. There are a couple of things I just wanted to highlight. One is that the new trust board has now been appointed, and it includes executive directors from Southern Health, from Solent, from the island, and also some new exec directors coming to join the trust. I have been appointed to the new trust board in the role of Director of Quality Improvement and Engagement. So I'm really pleased that I'll be able to continue my work in the new organisation and continue with my links with the island following its formation. I guess the other thing that would be wanted just to highlight that would be of particular interest to you is that the new trust is a foundation trust, and that works in a slightly different way from the Isle of Wight trust. It means that we have a number of constituencies, and additional constituencies will be added to the current Southern Health Foundation Trust constituency, and that includes the Isle of Wight, Portsmouth, and a constituency for people who use services, which I think is a really pleasing thing to see. From an Isle of Wight perspective, we'll have both staff and public governors appointed to that constituency, as well as appointed governors from statutory bodies. And we're starting some work to look at recruiting members and through the membership recruiting governors to the Foundation Trust. And then if I could just go on to the Afton part, I'm really sorry that we didn't manage to get the slides to you in time for the papers to come out, but I understand they have now been circulated. The reason it was delayed was that we had a planned outcome of the pilot, which I think was 2 days after the papers were due to be submitted, and I wanted to make sure that you had in front of you the most up-to-date information about the pilot. Some of you will remember well that this pilot came out of a few triggers. The first was that the inpatient mental health dementia ward that we previously had on the island, called Shackleton, was closed in 2019 as a consequence of quality concerns, in particular related to the workforce staffing levels. That closure of that ward enabled us to do was to divert some of the funds that we had used to run the ward to establish a dementia outreach team, or DOT we call it. And that has been an incredible success story and has really significantly reduced the length of stay for people who do need admission to mental health dementia beds, and has reduced the demand on those beds. As a consequence, the number of people needing inpatient care has fallen, but in our prior to the pilot, the vast majority of those people had to go to the mainland to receive mental health dementia care. That has become increasingly challenging to identify beds given the pressures in the systems, clearly there's a concern about people being so far away in such vulnerable circumstances, and often with very elderly and vulnerable carers needing to visit as well. And then the final kind of trigger for this was we had a CQC report inspection in Afton ward. Now, Afton is our older people's mental health ward. And we were, at the time CQC came, experiencing real pressures in 7 Acres, and we were having regularly people who were of a working age, so not older people, needing to be admitted to Afton Ward, and occasionally having people with dementia as well, but it was predominantly working age adults in an older people's ward that raised real concerns from CQC. And so we looked at all of that and pulled together a quite a diverse group of people who've been supporting us with this pilot and developed a model. There have been two key elements. One is to turn Afton Ward into a ward that would both be for older people with mental health problems and for dementia. And in order to do that, we've actually closed 2 of the beds on Afton because we've needed more space. When you're caring for people in a mental health environment with dementia, you need space to walk, space for people who are agitated, and we also need to care for the people with mental illness and with dementia slightly separately, although there's a huge overlap between the two. The other element of it was to enhance the dementia outreach team approach, so increase their hours of working, but also have them work very closely with Afton Ward in reaching and then supporting discharge for people. The impact of the pilot has been really positive. We've been successful in avoiding mainland mental health dementia admissions. We still have some people going to the mainland, and we think that we will always have a very small number who need particularly specialist care. But we're really confident that we've minimised this as a consequence of these changes. We have been successful in reducing the number of working age adults in Afton Ward, and that's now absolutely an exception rather than as it was a regular occurrence. And we've managed to do that without sending working age adults to the mainland, because that was one of the other risks, that we'd just switched the problem to a different patient group, but we haven't. And actually, the 7 Acres has done an incredible job in managing these changes with 2 fewer beds than they had previously. So all credit to the whole of the unit, not just Afton Ward. Afton Ward staff have received dementia training. Their working relationship with the dementia outreach team has been really strong and positive, and they've been able to continue to be safe through the pilot, despite the challenges that come with mental health dementia care. And that's partly because of the training and also partly because we've enhanced the skill mix. So we now have more staff on Afton Ward despite fewer beds. And it's all been delivered within existing budgets. We haven't needed any additional.
I'm ever so sorry, Leslie.
That was it. I'm finished. That was the end.
I'm conscious of the time, but thank you. Perhaps I could make a suggestion, because this was an issue this committee's been concerned about for a long time. We perhaps set up a separate briefing about that, and perhaps a visit for members or some of us to actually go and visit Afton Ward, because I think that would be actually a useful thing to do, to actually physically see it. Is that possible?
Yes, of course.
That would be good. I'm just really good. Thank you for that report and update, and a very positive within that. Is everybody okay with that? We just note the point. Yes, Joanna.
Yeah, just to say, it's really positive that we've got beds back on the island and far less people are going to the mainland, and it's brilliant news. Just one question. Did you get any feedback from patients and families as part of the evaluation of the pilot?
Yes, there have been. The patient experience team has been supporting the pilot, and we've had positive feedback from patients, from carers, and from staff. And of course, the most important thing is that we're not sending people off island in terms of experience, because I think we've kind of been able to remove that very negative experience that we know people were having, or at least minimise it.
Thank you, Leslie. You got one quick point?
Chairman, I'd just like to just make an observation of where the journey that we've gone on in the last few years with mental health. I think from before the time that you actually came as a mental health practitioner to the Isle of Wight, and particularly the strides that have been made under Leslie's tenure. And I think, perhaps on behalf of the committee, just a vote of thanks to Leslie and appreciation for the great work that she's done.
Thank you, John.
That's very important. It's very important to praise. It's very easy to criticise, but I think if we can finish this meeting on your particular item to say, well done, Leslie, and thank you for it. And I think it's also significant that we're now part of a mental health trust, because for many years, the Isle of Wight was the only place in the whole of the country that was a department and not a proper foundation. So I think that is an achievement in itself. Thank you very much, Leslie. If we can quickly bomb through the rest of the agenda. We've already spoken under the work plan to do with dentistry, which was the biggest issue. We've done that. So I think we're happy that we move on. 12, any members' questions? Thank you. I then end this meeting 4 minutes before 8. Thank you very much for coming. And it's been an extremely useful meeting. We've covered a lot of ground tonight. Thank you.